There is a symptom that millions of seniors carry every single day that their doctors have attributed to their spine, their muscles, their posture, their arthritis, or their age, and that they have been managing with pain medications, physical therapy, heating pads, and acceptance, that in a significant proportion of cases is not coming from any of those sources. It is coming from two organs sitting immediately beneath the lowest ribs on either side of the spine, quietly failing to do their job, producing a dull aching pressure that the person experiences in exactly the same location as spinal pain, and that they and their doctor, without the right investigation, have no reliable way to distinguish from spinal pain based on symptom location alone. The kidneys sit in the retroperitoneal space, behind the abdominal cavity, in front of the back muscles, beneath the lower ribs. Their anatomical position means that when they are inflamed, distended, obstructed, or under the stress of reduced filtration capacity, the sensation they produce is referred to the lower back in the same region where lumbar disc disease, facet joint arthritis, sacroiliac joint dysfunction, and paraspinal muscle strain all produce pain. A patient with kidney-related low back pain and a patient with degenerative lumbar disease may describe their symptoms in language that is nearly identical. The difference is what is actually causing the sensation, and therefore what will and will not help it. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. Lower back pain is one of the most symptomatically diverse presentations in medicine, and the causes range from entirely benign to requiring urgent attention. If your lower back pain is severe, sudden in onset, accompanied by fever, or associated with changes in urination, including blood in the urine, please seek medical evaluation today rather than continuing to watch this video. Subscribe to this channel right now if you are not already. This is exactly the kind of research I cover every week. The clinical connections that explain why the treatment you have been given is not working because the diagnosis it is based on may be incomplete. Subscribe now, it is free, and stay with me. Let me start by explaining the anatomical basis for why kidney pain is so consistently misidentified as spinal or muscular back pain, because this confusion is not a failure of attention. It is a direct consequence of the way the nervous system maps visceral sensation. The kidneys are innervated by the renal plexus, which receives input from the splanchnic nerves originating at the T10 through L1 spinal segments. When the kidneys produce afferent pain signals traveling from the kidney to the brain, those signals travel along the same nerve pathways and enter the spinal cord at the same segmental levels as the somatic nerves that carry sensation from the lower back muscles, the lumbar facet joints, and the sacroiliac region. The brain, which has no direct way to know which tissue at that spinal segment is the source of the signal, refers the sensation to the body surface area that corresponds to those segments, which is precisely the lower back and flank. This phenomenon is called referred visceral pain, and it is the same mechanism by which cardiac ischemia produces left arm pain and appendicitis produces periumbilical pain before localizing. The organ producing the signal and the location where the signal is perceived are not the same place. In the case of kidney pain, the mismatch is particularly confusing because the kidneys are anatomically located in the back, so even the direction of the referred pain feels anatomically plausible. A patient experiencing kidney inflammation does not feel pain in an obviously wrong location. They feel it exactly where they would expect to feel lower back pain, because the nerve pathway overlap means the brain interprets kidney origin signals as lower back signals. The clinical consequence of this overlap is that every year, millions of seniors with kidney-related lower back pain receive diagnoses of lumbar disc disease, facet joint arthritis, or paraspinal muscle strain because the physical examination findings, tenderness to palpation in the paraspinal muscles, limited range of motion, pain with movement, are also present in kidney-related pain and do not reliably discriminate between the two. And the treatment those seniors receive anti-inflammatory medications, physical therapy, muscle relaxants, spinal injections, addresses the musculoskeletal structures while leaving the kidney pathology entirely uninvestigated and untreated. Now I want to describe the specific kidney conditions that most commonly produce lower back pain in seniors, because this is not a single entity. There are 4 distinct kidney conditions that each produce lower back pain through different mechanisms, and that each require different investigations and different interventions. The first is kidney stones, nephrolithiasis. This is the condition most people think of when they consider kidney-related back pain, and it is one of the most common urological conditions in adults over 50. Kidney stones form when the concentration of stone-forming minerals, calcium oxalate, uric acid, calcium phosphate, struvite, in the urine exceeds their solubility threshold and crystals begin to aggregate. Small stones may remain in the kidney for extended periods, producing a dull, constant aching in the flank and lower back that many patients describe as exactly like a muscle ache. The dramatic, severe colicky pain that most people associate with kidney stones, renal colic, occurs when a stone moves from the kidney into the ureter and becomes lodged, causing ureteral spasm. But before stones reach the ureter, while they are still in the kidney, they often produce a persistent, moderate-intensity aching that is easily attributed to muscular or spinal sources. Research published in the Journal of Urology has found that the prevalence of kidney stones increases significantly with age, affecting approximately 11% of men and 6% of women over 60 in the United States, with higher rates in populations with elevated dietary protein intake, chronic dehydration, and metabolic syndrome. Seniors are in the highest risk demographic for stone formation due to reduced kidney concentrating ability, reduced fluid intake, higher rates of metabolic syndrome, and the frequent use of medications that alter urinary calcium and uric acid excretion. Many seniors have small stones producing chronic low-grade flank pain that has never been attributed to the kidney because it was never investigated with the right imaging. The second kidney condition is pyelonephritis, kidney infection. Bacterial infection of the kidney parenchyma produces inflammation, swelling, and pain in the kidney itself, referred to the lower back and flank. Pyelonephritis in young adults typically presents dramatically: high fever, chills, rigors, severe flank pain, nausea, making the kidney origin obvious. In seniors, the presentation is frequently atypical and muted. Fever may be absent or low grade. The pain may be mild to moderate rather than severe. The urinary symptoms that typically accompany urinary tract infections, dysuria, urgency, frequency, may be absent if the infection has ascended directly to the kidney without prominent bladder involvement. The result is that kidney infection in seniors presents as vague lower back discomfort with mild systemic symptoms that are attributed to fatigue and aging rather than to infection. A study published in Clinical Infectious Diseases found that atypical presentation of urinary tract infections and pyelonephritis is significantly more common in adults over 65 than in younger adults, and that delayed diagnosis in the senior population is associated with substantially higher rates of bacteremia and sepsis. The muted inflammatory response that produces the atypical presentation in seniors is the same age-related immune dysregulation that makes other infections present atypically in this population. The diagnostic implication is that any senior with new or worsening lower back pain, accompanied by even mild systemic symptoms, low-grade temperature, increased fatigue, mild nausea, cloudy or odorous urine, should have a urinalysis and urine culture performed before the pain is attributed to musculoskeletal causes. Subscribe to this channel right now if this is opening up a clinical perspective you have not considered. This is exactly the kind of research that changes the next conversation you have with your doctor. Tap subscribe. It is free, and I will make sure the follow-up content finds you directly. The third kidney condition is hydronephrosis, the accumulation of urine in the kidney due to obstruction of urinary outflow. Obstruction can occur at multiple points in the urinary tract. A kidney stone lodged at the ureteropelvic junction, ureteral compression from an enlarged prostate, a uterine fibroid or pelvic lymphadenopathy, ureteral stricture from prior infection or instrumentation, or external compression from an abdominal or pelvic mass. When urine cannot drain from the kidney, the collecting system distends, the kidney becomes progressively swollen, and the stretching of the renal capsule, the fibrous membrane surrounding the kidney, produces a persistent, pressure-like aching in the flank and lower back that is dull, constant, and positional. Hydronephrosis is particularly relevant in the senior male population because benign prostatic hyperplasia, prostate enlargement, is extremely common with age, affecting an estimated 70% of men over 70, and can produce bilateral ureteral compression and bilateral hydronephrosis without producing the dramatic urinary retention that brings patients to emergency departments. A man with mild to moderate prostatic obstruction may have chronic bilateral kidney distension, producing a constant bilateral lower back ache that has been attributed to lumbar degenerative disease for years. The connection to the prostate, and therefore to the kidney, is never investigated because nobody asks the right question. The fourth condition is the one I find most important to discuss because it is the most prevalent, the most silently progressive, and the most consequential if missed: chronic kidney disease with renal capsular distension. I described in a previous video how chronic kidney disease affects approximately 37 million Americans and how 90% of cases are undiagnosed until advanced stages. What I want to add to that picture now is that as chronic kidney disease progresses and kidneys begin to fibrose and scar, there is frequently a component of renal capsular irritation that produces a persistent, diffuse lower back and flank ache. This ache is not a prominent feature of all chronic kidney disease. Many patients have no pain at all, but in a subset of patients, particularly those with cystic kidneys, polycystic kidney disease, or rapidly progressive fibrosis, capsular distension is a real and persistent source of lower back pain that is almost universally attributed to the spine. Now I want to give you the clinical examination findings that help distinguish kidney origin lower back pain from spinal and muscular lower back pain because there are specific signs that can be elicited at the bedside that change the diagnostic direction. The most important bedside sign is the costovertebral angle tenderness test, CVA tenderness. The costovertebral angle is the triangular space at the junction of the lower rib cage and the spine on each side of the back, precisely where the kidneys sit. To elicit CVA tenderness, a physician places the palm of one hand over the costovertebral angle and strikes it firmly with the other fist. In spinal and muscular lower back pain, this maneuver produces little or no additional tenderness beyond the baseline pain. In kidney origin pain, whether from infection, stones, obstruction, or capsular irritation, this percussion technique produces a distinct, sharp, disproportionate tenderness that is clearly greater than the baseline ache. It is a simple, non-invasive bedside test that takes 15 seconds and that any physician can perform. If your doctor has been treating your lower back pain without ever performing this test, you can ask them to do it at your next appointment. The second distinguishing feature is the relationship of pain to movement and position. Spinal and muscular lower back pain is characteristically worsened by movement, by bending, twisting, prolonged sitting, and prolonged standing, and relieved by lying still in a supported position. Kidney-related lower back pain is considerably less position-dependent. It may be constant regardless of position, may be present even when lying completely still, and does not consistently worsen with the specific movement patterns that aggravate spinal pain. A patient whose lower back pain is no better lying flat than it is standing, and who does not find relief from the positions and maneuvers that typically reduce spinal pain, should have kidney pathology specifically excluded. The third distinguishing feature is the presence of associated urinary symptoms, even subtle ones. Spinal and muscular lower back pain is not accompanied by changes in urination. Kidney-related lower back pain may be accompanied by increased urinary frequency, nocturia, mild burning with urination, urine that appears cloudy or darker than usual, urine that has an unusual odor, or urine that foams persistently. These symptoms are sometimes so mild that patients do not report them spontaneously. They need to be specifically asked about. If you are experiencing lower back pain and any of these urinary changes, the kidney should be the first diagnostic consideration, not the last. Now I want to give you the specific investigations that should be performed when kidney origin lower back pain is suspected in order of priority. The first and most immediately accessible investigation is a urinalysis with microscopy, urine dipstick, and microscopic examination. This test takes minutes and provides information about the presence of red blood cells, which indicate kidney stones, infection, or trauma, white blood cells and bacteria, which indicate infection, protein, which indicates glomerular dysfunction, and casts, which are cylindrical structures formed in the renal tubules that indicate specific types of kidney pathology. A urinalysis costs almost nothing, requires only a urine sample, and can immediately confirm or suggest kidney involvement that changes the entire diagnostic approach. If your doctor has been evaluating your lower back pain without ordering a urinalysis, ask for one at your next visit. The second investigation is renal ultrasound, a non-invasive, non-irradiating imaging study that provides direct visualization of the kidney size, shape, cortical thickness, and collecting system. Ultrasound can identify hydronephrosis, kidney stones larger than approximately 3 millimeters, renal cysts, and gross structural abnormalities. It is the most cost-effective first-line imaging study for the kidneys and can be ordered by any primary care physician. A renal ultrasound accompanied by post-void residual measurement, a bladder ultrasound performed after urination to assess how completely the bladder empties, provides the additional information needed to identify prostatic obstruction as a cause of hydronephrosis in men. The third investigation is non-contrast computed tomography of the abdomen and pelvis, CT-CUB, which stands for kidneys, ureters, and bladder. This is the gold standard imaging study for kidney stones and provides superior detail compared to ultrasound for identifying ureteral stones, obstruction, and paranephric inflammation. It is associated with radiation exposure and is therefore not the first-line study for all patients, but in seniors with persistent lower back pain in whom a urinalysis shows red blood cells or in whom ultrasound findings are inconclusive. CT-CUB is the definitive next step. I want to add something about a practical clinical scenario that I think many people watching this will recognize. You have lower back pain. You have seen your primary care physician. You have had x-rays of your lumbar spine. The x-rays show degenerative changes, disc space narrowing, osteophyte formation, facet joint arthritis. Your doctor shows you the images and explains that the degenerative changes are causing your pain. You accept this explanation because the images show something real and the explanation seems complete. What nobody has checked is whether your kidneys are also contributing to the pain that your spine is taking full credit for. Because here is what the radiology literature is very clear about. Degenerative changes of the lumbar spine on X-ray are present in the vast majority of adults over 60, regardless of whether they have lower back pain. They are almost universal findings in the senior population. The presence of degenerative changes on imaging does not confirm that those changes are producing the pain the patient is experiencing. It confirms only that aging has occurred in that spine, which it has in essentially every senior who is being imaged. The degenerative findings are often a red herring, and a urinalysis that shows microscopic hematuria or a renal ultrasound that shows hydronephrosis may be the investigation that identifies the actual cause. Now, if you are finding this valuable, and if you are someone who has been managing lower back pain with treatments that have never fully worked, I want you to subscribe to this channel right now before you forget. Every week I produce exactly this kind of clinical analysis, the research that changes the diagnostic conversation. Subscribe, it is free, and it ensures this kind of content keeps reaching you. Let me also discuss the specific lifestyle and dietary factors that contribute to kidney-related lower back pain in seniors, because these are both risk factors for the conditions I described and modifiable elements that deserve attention. Chronic dehydration is the single most important contributor to kidney stone formation and to the concentration of inflammatory metabolites in the urine that irritate the kidney and collecting system. The The thirst mechanism becomes less sensitive with age. Seniors do not feel thirst as reliably as younger adults, even when they are genuinely dehydrated. And many seniors drink substantially less fluid than their kidney function requires. The target for kidney protective hydration is approximately 2 liters of water per day for most adults, sufficient to produce pale yellow urine throughout the day. Urine that is consistently dark yellow or amber indicates inadequate hydration and a urine environment that promotes stone formation and kidney irritation. High dietary sodium intake contributes to kidney stone formation by increasing urinary calcium excretion. Sodium and calcium compete for reabsorption in the renal tubules, so high sodium intake forces calcium out into the urine where it can aggregate with oxalate or phosphate to form stones. The dietary sodium recommendation for adults with a history of calcium oxalate stones, the most common stone type, is below 1,500 milligrams per day. This is substantially lower than the average American adult intake of approximately 3,400 milligrams per day. High dietary oxalate, found in spinach, nuts, chocolate, beets, and tea, contributes to calcium oxalate stone formation in susceptible individuals. This does not mean these foods should be eliminated from all seniors' diets. They have significant nutritional value. But seniors with a history of kidney stones or with persistent lower back pain and microscopic hematuria on urinalysis should discuss their oxalate intake with their physician in the context of their stone risk profile. Elevated uric acid from high purine intake, organ meats, shellfish, red meat, fructose, contributes to uric acid stone formation and to intrarenal uric acid deposition that produces a specific pattern of lower back and flank aching. Seniors with gout or with elevated serum uric acid on blood panels are at specific risk for uric acid nephropathy and should discuss dietary purine restriction and potentially allopurinol therapy with their physician. Here is the summary of everything we covered. Kidney pain is referred to the lower back and flank through the same spinal segments as somatic lower back pain, making kidney origin and spinal origin lower back pain clinically indistinguishable on symptom location alone. 4 kidney conditions commonly produce lower back pain in seniors. Kidney stones that produce chronic dull aching before producing the dramatic colicky pain of ureteral obstruction. Pyelonephritis that presents atypically in seniors without fever or dramatic urinary symptoms. Hydronephrosis from prostatic obstruction, stone obstruction, or external compression. And chronic kidney disease with renal capsular irritation from progressive fibrosis. The clinical signs that suggest kidney origin over spinal origin are costovertebral angle tenderness on percussion, pain that is position independent and not relieved by the maneuvers that reduce spinal pain, and associated urinary symptoms including frequency, nocturia, foam, discoloration, or odor. The investigations to request are urinalysis with microscopy, renal ultrasound with post-void residual, and CT-KUB if urinalysis shows red blood cells or ultrasound is inconclusive. Degenerative lumbar spine findings on imaging are present in the majority of seniors and do not confirm that the spine is the source of the pain being experienced. The modifiable lifestyle factors that contribute to kidney-related lower back pain are chronic dehydration, high sodium intake, high oxalate intake in stone-prone individuals, and high purine intake. Please share this video. There are seniors managing lower back pain right now with physical therapy, anti-inflammatory medications, and spinal injections for a cause that has never been investigated. Share this with anyone in your life whose lower back pain has not responded to treatment as expected, whose doctor has pointed to imaging findings as the explanation, or who also has any of the urinary symptoms I described. The information to change their diagnostic conversation is in this video. Subscribe to this channel if you have not already. My next video covers the complete dietary and hydration protocol for kidney stone prevention, the specific foods, fluids, and supplements with the strongest evidence for reducing stone recurrence and protecting kidney filtration function. Subscribe so it comes directly to you. I am Dr. Edward. Your back deserves the right diagnosis, not just the convenient one. I will see you in the next one.